Good evening, everybody. Welcome to today's topic on acupuncture, that is anterior interosseous nerve syndrome, Kilo-Nevin syndrome, motor branch of the median nerve. We will dive into the topic. Learning objectives: understand anatomy, symptoms, examination, and management. Proximal forearm, anterior front view, this is the biceps brachii, and target area: front anterior of the proximal forearm, pronator teres, flexor flexor profundus. The anterior interosseous nerve (AIN) is a motor branch of the median nerve. It passes through the proximal forearm, point to the front anterior to the of the proximal forearm, area between the pronator teres and flexor flexor profundus, just distal to the elbow crease. Median nerve review. Course of the median nerve and origin of the anterior interosseous nerve. There is the median nerve, brachial artery, pronator teres. Median nerve is from C5 to T1, formed by lateral root of C5 to C7 and medial root C8 to T1. Travels with the brachial artery in the arm. Recurrent branch motor. The branches in the proximal forearm supplies PT pronator teres. FCR flexor carpi radialis, palmaris longus is present, does not pass beyond the elbow. Anterior interosseous nerve AIN motor arises in the proximal forearm, passes between the flexor digitorum profundus, lateral part, and flexor pollicis longus. Supplies flexor pollicis longus, FPL, lateral half the flexor digitorum profundus, index and middle fingers, pronator quadrants, instant, we having distal branches, sensory, and thenar motor branches. So supply the palmar aspects of the thumb, index, middle, and radial half of the finger. Thenar motor branches, motor supply, thenar muscles, abductor pollicis brevis, opponent's pollicis, flexor pollicis brevis, superficial hand, head, and the lumbricals 1 and 2. Palmar cutaneous branch arises in the distal forearm, runs superficial to the flexor retinaculum, supplies sensation to the central palm. So you can see the picture. Forearm center, radius, ulna, proximal forearm landmarks is the anterior view. Lateral epicondyle, medial epicondyle, head of radius, and ulna is the carpus. So you can see each and everything. Anterior interosseous nerve anatomy. Mortal is applied to the flexor pollicis longus and radial FPP and pronator quadratus. So you can see the anterior interosseous nerve, flexor pollicis longus, pronator quadratus. Okay. Motor branch at the median nerve branches off in the proximal forearm, typically 2 to 5 centimeters to the elbow. Here is a branching diagram, different branch, motor to thenar muscles, anterior interosseous flexor pollicis, longus, flexor digitorum profundus, lateral half and index and medial pronator quadratus. So you can see everything. AN syndrome. Kilo-Nevin syndrome occurs due to compression of entrapment of the AIN, leading to the weakness of thumb flexion, index finger flexion, and forearm pronation without sensory loss. AN syndrome is a motor neuropathy affecting the anterior interosseous nerve. Causes include entrapment, trauma, neuritis, and repetitive forearm activity. Risk factors include overuse, fractures, surgery, and inflammatory disorders. Symptoms include weak pains, difficulty making the OK sign, no sensory loss. No numbness. AIN is purely a motor branch of the median nerve. OK sign test failure to make a round OK sign suggests an AIN involvement. The OK sign evaluates the function of the anterior interosseous nerve, a motor branch of the median nerve that supplies the flexor pollicis longus, a lateral of the flexor digitorum profundus, index, and middle. Ask the patients to make an OK sign by touching the tip of the thumb to the tip of the index finger. The patient should form a circle with thumb and index while keeping the other fingers extended, as you can see. Observe for weakness or inability to form. This is a positive test. You can see the demonstration also. Pinch strength test. Compare thumb index pinch with opposite side. Patient position. Patient seated comfortably. Shoulder erected. Elbow flexed at 90 degrees. Forearm in neutral position midway between the pronation and supination. Wrist in neutral position. Hands unsupported. How to perform? This is the thumb pad. This is the lateral aspect of the index finger. Adjust the pinch diameter to fit the patient. Ask the patient to pinch the device between the thumb pad and the lateral aspect of the index finger. Instead, pinch as hard as you can for 3 seconds. Record the reading in kgs or lbs. Repeat 2 to 3 times. So this is the normal. This is the weak suspected AIN. This is the severe weakness. You can see. Normal means spin strength is approximately greater than 6 kgs. Normal AIN function. Mild weakness 4 to 6 kgs. Mild AIN involvement. Moderate weakness 2 to 4 kgs. Moderate AIN involvement. Severe weakness less than 2 kgs. Severe AIN involvement or dysfunction. Differential diagnosis include pronator syndrome, tendon injury, cervical radiculopathy. Investigations include clinical examination, EMG or MCS, ultrasound or MRI when needed. Role of acupuncture may be included as part of comprehensive patient management. Exercises include beach strengthening and nerve gliding under supervision. Prevention, ergonomics, graded loading, and early evaluation. Management, activity modification, rehabilitation, and appropriate medical care. Anterior interosseous nerve AIN gliding exercise. Improve nerve mobility, reduce resistance, enhance forearm and hand function. Sit or stand tall, shoulder erected and externally rotated, elbow straight, forearm in neutral position, wrist neutral, fingers extended. Generally extend your wrist, extend all fingers and thumb. You should feel a gentle stretch in the forearm. Slowly turn your forearm out. The palm faces up, that is supination. Keep wrist and fingers extended. Gently move your thumb backward extension. Keep other fingers extended. You may feel the stretch along the inner forearm. Hold this position for 2 to 3 seconds. Stay relaxed and breathe normally. Slowly return to the start position. Repeat the sequence smoothly. So I repeat 10 to 15 times per session, 2 to 3 sessions per day. Then only you can see the benefits. The benefits are improves mobility of the AIN, reduces nerve adhesions and tension, enhances blood flow to the nerve, supports recovery in AIN compression or injury. Important tips is that move slowly and smoothly. Do not force the stretch. Keep shoulder down and relax. Stop if you feel pain, tingling, or increased symptoms. Consistency is the key to improvement. These can be benefited in AIN syndrome, Kilo-Nevin syndrome. That's what we are discussing. And apart from that, post-injury or post-surgery recovery, forearm tightness or stiffness, DP2 strain in forearm. Key takeaways are motor weakness without numbness is the classical feature. Thank you. We'll meet you tomorrow.